Good evening and many thanks for joining us on Engendered this evening. I am Victoria Agbi, and as you know, what we do on Engendered, we bring you issues regarding female genders. Today wouldn't be an exception. Like I said earlier, I am Victoria Agbi.
And I'm Pamela Ajaero. Welcome to the show this evening. We'll have lots of discussion for you this evening, but it will be coming after this break, so stay with us.
My name is Sheilo BCFR, the Black Comedian of the Federal Republic. I tell you, when it comes to the best of entertainment, the best of news, the best of information, something that is educative, you're right here at the best place to see that. It's Captain TV. You know what? Increase the volume. Keep watching. Don't touch the dial, okay?
It's your girl Nkechi Blessing Sunday. I want you all to keep watching Captain TV.
Please keep watching Captain TV. It is the best TV station in the country. They're doing an amazing job. Please do not touch the dial. Keep watching. Thank you.
My name is Sheilo BCFR, the Black Comedian of the Federal Republic. I tell you, when it comes to the best of entertainment, the best of news, the best of information, something that is educative, you're right here at the best place to see that. It's Captain TV. You know what? Increase the volume. Keep watching. Don't touch the dial, okay?
It's your girl Nkechi Blessing Sunday. I want you all to keep watching Captain TV.
Please keep watching Captain TV. It is the best TV station in the country. They're doing an amazing job. Please do not touch the dial. Keep watching. Thank you.
In a world where information is vital to every individual, a platform where technology is a medium to pass information, you can always catch up on all information written in the newspapers, even without having one. Join us on The Press.
Live from the Abuja studios.
On The Punch for this morning. The Blueprint newspaper, Nigerian Tribune this morning.
As we give you information and opinions about current events and topical issues on politics, business, sports, entertainment, weather forecasts, and lots more in the local city, across all states, and across all countries. Showing daily on Star Times, Channel 124, 9 a.m. West African time, only on Captain TV. Stay connected with us.
That he said it is a reason why I will not do it.
I pursue the federal government to pay us our damages.
YouTube, Captain TV.
A very tricky one. And then the bottom line is this.
Website www.captain.tv.
Point is, the youth must come together. The pendulum can swing in your favor.
Instagram, Captain_TV. Captain TV. Imagine a beautiful world.
Welcome back to the program. If you've just joined us, you're right on time because the show is about to begin. The ship is about to sail. Now we've been joined in the studio with our guest who will be discussing on our topic for today. And today's topic is infertility in women. And our guest, Dr. Goodangel Esther, a medical practitioner, will be doing justice to the topic. Welcome to the show, ma.
It's good to have you join us. Dr. Goodangel.
Goodangel. It's a name for me.
Huh? Tell us about the name.
Yeah.
Oh, okay.
So I'm expecting to hear something like Good Angel Unduka. But Unduka is not coming.
Oh, I actually have a major name, Ifunanya Chiko.
Oh, you are even Igbo. No wonder she stated Unduka.
So, what come about the Good Angel? This is the first time I'm actually hearing such name.
Okay, Goodangel is my surname as well as my name. So I just go with Goodangel.
Is your dad Nigerian?
Yes.
Okay.
I see.
Okay, that's nice. How is the economy treating you? How have you been with the whole drama in the country right now?
We are surviving by God's grace.
Right, we have to survive as a Nigerian. Anywhere it brings to our table, we'll survive on it. So, like I said earlier, we'll be discussing infertility in women, and we have a report here which says, according to a new report published by the World Health Organization (WHO), around 17.5% of the adult population, roughly 1 in 6 worldwide, experience infertility, and that is why we are about to discuss this topic this evening. Now back to our guest. Like you heard me read this report, what is the overview of infertility in women, and what are the contributing factors to this crisis?
Before I begin, I would like to say this topic is a very sensitive one.
Sure.
Yeah, so infertility is something that causes both physical, psychological, mental, medical detriments to the woman, as well as a condition that affects the couple. So infertility, according to the WHO, define infertility as a condition, a status of both the male and the female reproductive system. So when I define infertility in the woman, since we're focusing on female infertility, but infertility, the definition in general is inability to get pregnant after 12 months of regular unprotected intercourse. So it must be regular, it must be unprotected, 12 months, and then it has to be for a couple or a woman who is less than 35 years of age. And then this definition changes for a woman who is 35 years of age and above. It becomes 6 months of regular unprotected sexual intercourse. Once it's past this range, we can say, oh, there's infertility.
Okay, what are the contributing factors to this infertility in women?
There are a lot of causes to infertility. It's quite large. If we should start,
we should go into
everything.
Yes,
to go down, so we can get the insight.
Okay, it's large. So there are different contributing factors, say causes to infertility. One is what we refer to as the ovulation disorder, which I'll explain further. There is endometriosis. There is pubic adhesion or pelvic adhesion and tuber blockage. There's also hyperprolactinemia. I'll try as much as possible not to say a lot of medical jargons. So the first one, which is the ovulation disorder, it has to do with what we refer to anovulation or oligoanovulation. So what anovulation is there is just the absence of ovulation. And oligo-ovulation means something that is irregular. So this category of women that experience anovulation, most of them don't even menstruate. And then those that experience oligo-ovulation, they menstruate but it's irregular. So when a woman is not even, so there's not even that means to release egg. So there's no ovulation, so the release of egg is not there. So there's nothing to fertilize and there's no means of pregnancy. So when it comes to oligo-ovulation, it means it is irregular. Not that the woman doesn't ovulate, but it's completely, like you can't say, okay, it's not like it's there. So she can't tell, okay, I'm going to menstruate this month or next month. So, and you can't really say, okay, there's no means of ovulation as well, which there's no production of egg. So you can't get fertilized.
All right, I want to ask you, okay, I don't know if you're done with this.
No.
Okay.
Under anovulation, there are a lot of classes. There's merely like 3 classes under the anovulation. Number 1 class, it has to do with what we call hyperpituitary, like hypothalamic, whereby the brain is supposed to signal a particular hormone called the GnRH, which is the gonadotropin releasing hormone. This gonadotropin releasing hormone is like a messenger that tells another one that, look, it's time. Send the hormone to the ovaries, stimulate it so as to produce egg, so as to menstruate. The category of women in this case, it has to do with secondary amenorrhea. It means they've already had the experience of menstruation, but suddenly cease, or suddenly it becomes irregular. So these women, we can see those like with dietary disorders, those that experiences maybe excessive exercise, and then also some mental stress, and it also has to do with the kind of job they do, which also can lead to mental stress. So this stress, it causes a hormone to increase called cortisol. It's like a stress hormone. So cortisol then decreases the GnRH that I told you is the gonadotropin that the brain stimulates. So the increase in cortisol decreases that hormone. Because it's decreasing that hormone, the hormone too is decreased. It can call the other hormone called pituitary gland to say, okay, stimulates these hormones that will produce these certain things. That's only for one class. There's another class of that's anovulation. That's either absence of ovulation or irregular ovulation. It has to do with something I'm sure a lot of women know about this, PCOS, which is polycystic ovarian syndrome. In this particular category of women, there's something we refer to as the Rotterdam criteria. It has 3 criteria. Once we are able to assess these 3, 2 out of these 3, we can easily diagnose a patient with PCOS. These patients, we can use what we refer to as the chemical biochemical analysis. Here they experience hyperandrogen. Hyperandrogen, where you see some women with facial hair, there is hair on their chest, severe acne, irregular menses, and then there's painful sexual intercourse. They experience painful sexual intercourse. Sometimes they also experience decrease in sexual drive. This category of women under those with polycystic ovarian syndrome. And when we use ultrasound, we notice multiple cysts, which is why it's called polycystic. There's multiple cysts on the ovaries. So that's category of another set of women. It's a whole lot. I say we need to go deep into it. Is quite wide.
Yeah, I hear you said you're not going to use jargons, but there's medicine now. You cannot run away from those terminologies. However, I feel like perhaps you help us reduce the terminologies a bit and tell us the signs. I know you mentioned low drive for sex and the rest. So tell us some things you think these women who go through infertility at early stage, they might not know that, or this is something that might likely happen in future, but there are signs from the initial beginning. Tell us some of those things that those women will experience.
The main symptoms of infertility is the inability to conceive. That's the main symptoms. But
there are no signs before then.
Yeah, however, there's signs. A woman who experiences and has what we refer to as endometriosis is something most women have been hearing about. They experience the painful menstruation, like severe cramps. What happens is that in the walls of the uterus, or like I said, the womb, there's something that lines it. So in certain way, this thing that lines the walls of the womb, it removes, like a part of it removes. It's supposed to be in this location, but it moves to a location that is not its own. So it causes those severe pain in these women. They experience painful sexual intercourse. They experience irregular menses. When they're on their period, the pain is so severe to handle. Some of them even using medications like pain relief and all that, it doesn't even help them. So when already these signs, and so some women also, there is also something called PID, which is pelvic inflammatory disease. It has to do with infection, maybe sexually transmitted infection. They've been treating over and over, because the more they keep on treating sexually transmitted infection, it decreases their chances of getting pregnant in future.
Really? So you shouldn't treat it?
No, you treat it, but when you already have these signs, it's something you should be like, you begin to, not that that's why there's protection. Then the question was, what are the signs, even before it gets to that? So a woman, before she gets married or trying to conceive, okay, I've been treating these and all that. I've been experiencing irregular menses. I've been having severe cramps during my menstruation. I've been having pain when having sexual intercourse, and some of them, when they are going to toilet, they will have pain trying to pass out too. So all these signs, if you already have all these things, you already feeling that, I should already analyze myself even before I get there, because these are the signs of either the person has endometriosis or have pelvic inflammatory disease, which is the infection, which is mostly caused by chlamydia or gonorrhea. They are sexually transmitted infection. So when a woman is seeing all these signs, she should, and then severe acne, facial hair in the chest, nail pattern, like all those kind of signs.
Are those signs of infertility too?
No, those ones are signs of polycystic ovarian syndrome. That was what I was explaining earlier on. So when a woman have those kind of signs, you should already know that, okay, I should know that these things are chances, there are percentage to it.
Yeah.
There's women that have uterine abnormalities, such as maybe fibroid. Some women have fibroid and they can easily conceive. And some women have fibroid as well and they can't conceive because of the location of the fibroid. So these are when a woman is experiencing all these signs, she already starts thinking, okay, maybe I should analyze myself, I should do this and that.
Okay, just to state it, just to make it clear, because I know you stated it earlier. Does it mean that after like a year, like how long should a woman stay before she suspects that she's having infertility issues? I know you said 12 months earlier, but I just wanted to make it clear.
Okay. When a woman is trying to conceive and she's below the age of 35, it's 12 months. I think there's something referred to, I'm trying not to use medical jargons as well. There's something referred to as fecund ability. It means that the ability to get pregnant in one menstrual cycle. That is during that your one ovulation, the ability to get pregnant. This percentage increases according to months. Not all couples. That's why the definition of infertility, it has to be that the woman is having regular, unprotected. If it's regular, but it is protected, maybe with birth control or any form of birth control, it decreases the chance. There's no way she can get pregnant. But it has to be unprotected and 12 months. So after 12 months, she should try to start, like, that some women, even after 1 year, they can get pregnant. But that's after 1 year, and there's a regular, unprotected, you should seek evaluation. And then when the woman is like 35 and above, once it's 6 months, you should start seeking.
Okay, I was going to, sorry, Pamela, I was going to ask you when should one seek evaluation, which you've answered. However, I'll give you an instance where I know someone that did not see her ovulation. She didn't experience ovulation for like 2 months, so she went to the doctor and they did want to check up on her, test and the likes, and they told her some things like, oh, you only have one ovary, you can only have one child, or you may not even have a child, and something. So she had already started even crying and saying, I will not have a child, or what am I living for, and the rest of it. And then she had unprotected sex and got pregnant. This was a lady that didn't see an ovulation. What do you think could have happened at that time?
No, I'm sure when she went to the hospital, they gave her some certain kind of medication. Nothing. Yeah. Maybe she's experiencing oligo ovulation, meaning that she's having irregular menses. When you said she didn't experience ovulation, doesn't mean she didn't menstruate for that 2 months.
She menstruated.
She menstruated. But how did she know that she wasn't ovulated?
The signs were not there. And yes, the things that the discharge that comes out when you are ovulating and the likes, were not there.
No, some women, they are setting this thing, our hormones changes every month.
That's what I want to say.
Yeah, our hormones change. This month now, I might be experiencing like mood swing. I might be experiencing bloating. Next month, I won't feel anything. So our hormones changes with time.
As well as she saw her menses, of course, ovulation will come after that. That's just normal.
All right, I was still going to ask you, you spoke about evaluation, and you said at some point, you've mentioned some times where a woman who is experiencing infertility should see a doctor. But I want to also ask how safe it is in addressing infertility, because in some instances when you go to the doctor will say, calm down, wait first a bit, don't be in a hurry and the rest. And most times these women are usually impatient and they want to just like perhaps give birth after 1 year or after 6 months and the rest. One is already crying that I don't understand what is happening and the rest. I know you're giving a duration, but can you analyze it?
Yeah, I actually have this personal experience, a family member that got married, and then in less than 5 months into her marriage, she was calling crying. I'm like, what's going on? It was like, I've not gotten pregnant, it's already 5 months. I'm like, why are you worried? It's just 5 months, she just got married. And she's like, no, my in-laws are already sending me a message. They're telling me something like, we don't have barren women in our family, and we don't have these. I'm like, it's 5 months, there's nothing to worry about. You have to wait, and your husband is the one that is always traveling. So it's not even with you, there's no that regular according to definition. So you have to wait for like 12 months for you to start getting worried. I said, so there's nothing. She was kept on, she was afraid and all. I was like, okay, since I was not close to you, you can go to the hospital and see a doctor. And so when doctor said, oh, just calm down, it's because you have not crossed the line for them to say, oh, you are infertile or start evaluation. They will just have to reassure you. Yes.
Okay, let's talk about genetics. How does genetics affect, like what role does genetics play in this female infertility?
I didn't get that. Genetics.
Okay,
genetics, okay.
As in, what role does it play in female infertility?
Oh, it has a lot. It has to do with a category of women. There's something referred to as congenital uterine abnormality. There are certain women that fall into that where they don't, I don't know how to put it. I'm trying as much as possible not to use a lot of terms. But there is also a congenital abnormality where we refer to as premature ovarian failure, premature ovarian insufficiency. Women in this category, the hormone, that same hormone I mentioned, GnRH, is decreased. So the ability to produce what will stimulate egg production is very low. And then there are certain women, you know, as a woman, we have chromosome referred to as SS. And then for a man, it's XY. But there are certain category of women that fall into just X.
Really?
Yes. We call Turner syndrome. Those women, they can't even produce, they don't have the ability to produce the follicle. Follicle is like a sac in the human ovary where the egg is being produced. So they don't even have the ability to produce it because they only have one X.
But so can diagnosis tell you?
Yes. Diagnosis can say there's something we call cryotyping. It's like a genetic testing when you go to the hospital. That's why during evaluation there are a series of things, but every woman has their own. After it's spoken to you, we take a lot of history. We take your history of the age when you start your menstruation. Do you feel pain during your menstruation? What's the length of your menstruation? Is it heavy? Is it light? All those history, your sexual history, we take all those history. Have you been pregnant before? Because when you talk about infertility, there are certain women that give birth to one child and then they're not able to give birth to another. That one is secondary infertility. So we ask all those questions. So when we're able to get all the history and analysis of this particular patient, because every patient is unique, so we know how to direct your own form of evaluation.
What can age affect fertility?
Oh, that's a big yes. That's a big yes. Yeah, because just like we had said, once you're below 35, it's 12 months. And then when you are 35 and above, it's 6 months. And again, for a child, first of all, a 20 weeks old baby in the womb has the ability to produce over 6 million follicles. This follicle, remember, is like a sac where the egg is being produced. So a baby in the womb, a baby girl, has ability to produce 6 million. Once the child is born, it decreases to approximately 1 million. And then when the girl gets to puberty, it decreases to 300,000. And this is how we keep losing follicle as we age.
Wow. So a girl child can give birth to 300,000 children.
It has the ability to produce, it has a tendency to produce 300,000 follicles. So but as we age, it keeps decreasing. Each menstruation, we are losing egg. So as we age, it keeps decreasing. So both the quality and the quantity decreases with age.
So that's the more reason you have to give birth on time, because the more menstruation you see, the more the likely chances you have to give birth. Wow. Okay.
This is really amazing. Okay, let's talk about lifestyle factors. Does it affect fertility? Like, for example, there are people who eat a lot and they eat particular things. Does that affect their fertility?
Yeah, I'll say a very big yes, because first, lifestyle modification.
Okay.
Yeah, certain people, when they come to the hospital and we see them, we just notice that this thing, just do this or do that, and you see things changes. Yeah, some women, they engage in smoking, excessive exercise, also alcohol intake. We advise, if you are smoking, please, and you want to get pregnant, please just stop. If you are drinking, just stop. And then, so all this lifestyle modification, once they are able to stop it, it helps. Because remember I said, like, like maybe excessive exercise or stress, some people will just tell them, please don't think. But if you're overstressing, it decreases, it affects you. Like you are crying, you're still trying to, you're overstressing, or the kind of job you do, mental stress and all, it decreases your chance. Because like I said, it makes, there's this stress hormone to increase, which decreases your chances of producing, of ovulating. So lifestyle modification is very important.
Okay, I also want to ask, I know menstruation is very important, especially for women who wants to get pregnant and the likes. And earlier you spoke about hormones. Our hormones could change at any moment and the likes. For women whose hormones like changes per time or something, is it advisable to see a doctor or a patient? Because I know some ladies, like, they've not seen their period, like, and they didn't have sex, but here they panic. Like, oh, I've not seen my period, or like it's 5 days after. Is it advisable to go see doctor at that stage, or just stay and wait for it?
Okay, there is a normal range for the menstrual cycle, 21 to 35 days. Some women just know that, oh, it's 28 days for me. Some is 35. Once it's less than 21 days, it's already a flag that, oh, let me check myself out. When it's over 35 days, you should check yourself out. It might not be, pregnancy is not only the factor that seizes menstruation. There are a lot of things that can seize your menstruation.
Like what? Infection.
Yeah, thank you. The infection.
Oh, Dr. Pamela.
Like I remember when I was in secondary school, boarding school, only girls' school. So I just came back and I was meant to see my messes and I didn't see. I was not panicking because I knew I didn't sleep with any man. But my mom was like, she was just asking me funny questions. I was just in SS1, like I was never thinking of any man. But she was panicking. She took me to the hospital. But I just had that confidence in me that I've not though. So we have to go run tests and the rest. And the doctor said it was infection. That was when I knew that, oh, so infection also do these things. So that was when I
even stress. When I was in medical school, we can get so stressed that you see how many girls complain, I didn't see my period this month. I didn't see, just because of stress. So all those ones too are factors. Like, it's not only pregnancy that we just see it. Infection, stress, and the one also I talk about, a woman can just see that, oh, before I'm not experiencing any sign of polycystic ovarian syndrome, PCOS, or it can even be the thyroid. So women go through thyroid disease or so, and they don't even know, and it can also affect their fertility.
What and thyroid disease? Sorry, I'm asking too many questions.
Okay, I don't know. There's where these certain signs women see that has thyroid disease. They experience cold feet, cold hands. Some of them, like, the weather is very hot, they'll be complaining, I'm cold. I'm always cold when everywhere is hot. And then when everywhere is cold, or when everywhere is hot, they are cold, or when everywhere is cold, vice versa, they are hot. There are certain signs. It can be either increase thyroid hormone or decrease. So either one can also affect fertility and also affect their menstruation.
Indeed, so much to learn, and we have so many questions to ask. But before we continue, let's quickly go on the short break, and when we return, Engender, continue, stay with us.
Let's be fast with our chores. It's almost time for Engendered. Girls, it's time for your favorite program, Engendered. Yeah, Mommy, we're coming right away. Sophia, turn off the gas. What are your fears as a woman? And what are your doubts as a lady? You think you're alone with those thoughts? Then welcome to Engendered, where we'll bring you discuss, interviews, previews, experiences, opinions on issues relating to the female gender. This is Engendered.
My name is Sheila BCFR, the Black Comedian of the Federal Republic. I tell you, when it comes to the best of entertainment, the best of news, the best of information, something that is educative, you're right here at the best place to see that. It's Captain TV. You know what? Increase the volume. Keep watching. Don't touch the dial, okay?
It's your girl Inkechi Blessing Sunday. I want you all to keep watching Captain TV.
Please keep watching Captain TV. It is the best TV station in the country. They're doing an amazing job. Please do not touch the dial. Keep watching. Thank you.
In a world where information is vital to every individual, a platform where technology is a medium to pass information, you can always catch up on all information written in the newspapers, even without having one. Join us on The Press.
Reaching live from the Abuja studios.
On The Punch for this morning. The Blueprint newspaper, Nigerian Tribune this morning.
As we give you information and opinions about current events and topical issues on politics, business, sports, entertainment, weather forecast, and lots more in the local city, across all states, and across all countries. Showing daily on Star Times, Channel 124, 9 a.m. West African time, only on Captain TV. Stay connected with us.
That he said it is a reason why I will not do it.
I pursue the federal government to pay us our damages.
YouTube, Captain TV.
A very tricky one. And then the bottom line is this.
Website www.captain.tv.
Point is, the youth must come together. The pendulum can swing in your favor.
Instagram, Captain_TV. Captain TV. Imagine a beautiful world.
Please, girls, let's be fast with our chores. It's almost time for Engendered. Girls, it's time for your favorite program, Engendered. Yeah, Mommy, we're coming right away. Sophia, turn off the gas. What are your fears as a woman? And what are your doubts as a lady? You think you're alone with those thoughts? Then welcome to Engendered, where we'll bring you discuss, interviews, previews, experiences, opinions on issues relating to the female gender. This is Engendered.
Thanks for staying with us on the program. We've been discussing infertility in women with our guests seated on the studio here, Dr. Goodangel. Okay, we've really thrown so much insight on the topic for today. Now I want you to tell us, how does this infertility affect women psychologically, emotionally? And also, I know sometimes it's not just the women now. It also affects the partner, it affects their relationship. How does it work?
Okay. You know, when we talk about infertility, it's just because we're focusing on the female factor, the female part of infertility. If we should draw a pie chart, there's a percentage that has to do with women infertility, male infertility, both like the combined infertility, and what we refer to as idiopathic. It means there's no non-factor. Why? What's causing that infertility? So for the female, the thing is that especially in our society, or will I even say the world at large, is that when a couple cannot put to bed, the blame just goes on the woman, especially in our society. So there's this cultural thing, just like I said now, like a family member of mine, 5 months, she was already being told, we don't have any barren people in our family and all that. So the woman gets more of the burden. No one even tend to say, oh, let's go and do tests. This stuff is like, no one is doing it on their own. There is something causing it. So if these women or this couple, they need a collective, like people to support them. Everyone needs to support. If they should go to the hospital, the doctors, everyone, they need to support. They need to make them feel this is not your fault. Family should understand this is not their fault. Everyone should put their hands together to look for a solution.
Okay. Yeah, talking about support, like everyone putting their hands together. Sometimes you approach a woman. You wouldn't call such a woman barren, because the Bible says none among you shall be barren. However, okay, because they are unable to conceive a child per time, there's this kind of hate they get, like they feel kind of, perhaps they don't want to socialize with people. When they see children, they are not happy. Only few of them, when they see children, are happy to even accommodate other children, and they feel like they should be isolated. They are always on their own. Sometimes even at home, they become very complex to deal with, and the rest with family members. So sometimes, even as a relation, as a close friend, you are scared. How should I go support this woman, and what should I tell her? What's the right words to use on her? Because you don't want to be stepping on toes or making her feel as though she's neglected, or perhaps she's not doing the right thing, or maybe. So what's the right approach into, like, perhaps supporting such couples in such a situation?
You know, when it comes to the infertility, the discussion infertility in family, a woman can easily just begin, oh, I'm the only one receiving this burden. Even if their husband is going through a lot, but it's them, the society is looking at them. So there is the financial part of it, which once there's so much money going into it, there's this, both even the men begins to get, I'm putting so much, there's nothing coming out of it. Yeah. So when you see a woman going to this, really, what do you say to them? You just let them know, if they want their space, fine, but just know I'm there for you. I understand. I'm praying for you. But at the same time, if you have the opportunity to advise them, see a doctor. It's very important to see a doctor. To advise
Okay, so you spoke about the financial aspect of the whole thing. It's complex still, because sometimes they want to go for IVF. It gets to that extent, or surrogacy. It all costs money. Seeing doctors. Even to see a doctor in a hospital for ordinary malaria, I will never forget this experience. I was telling Pamela the other day, I know how much I had to spend, not to talk of fertility issues. They'll tell you need to check hormonal imbalance, and each hormonal imbalance is cost around like 4,500, 6,000 thereabouts, and you have to test like maybe 4 thereabouts or 6, and you do this maybe every month, or depends on what you are testing and the rest of it. This is all accumulates a whole lot of money, and not everyone, most of the people who suffer from this, according to a survey, my research I did, it's even more on the rural area than even the urban. Okay, I know that there are people who suffer from it in the urban, but it goes to the sub-Saharan areas more when the issues of infertility. So that means the money there's usually not enough money to seek help medically, and which brings us to the issue of finance. So do you feel people can go for alternatives like herbal medication when there is need?
Yeah, for me, I don't preach about herbs, because if it's not something, like, I would never tell you, oh, these are the herbs to take, or this, that. But according to, like I said, every woman is unique, and the cause of their infertility is unique to them. So for some women, there are certain medications we place them on. There are certain women that don't menstruate, and there are certain medication we give them to stimulate menstruation. And then there are certain women we give certain medication to induce ovulation. So if a woman have tried, there's like maybe two lines of medication we give women. The first line has 2 medications to it, and then the second line has another one. If a woman has tried this, then, or women who has tuber factor, or maybe there's tuber blockage, I don't know if you've heard that, or uterine abnormalities, those things that, or even if you take drugs cannot help and all that, that we then shift to the IVF. But first, certain women are placed on medication. So I know all these things still cost money. IVF costs money. Even to do artificial insemination, intrauterine insemination is also costs a lot of money. I had worked in a fertility clinic during my intern year, So I see women that come there. There are a lot of these things we give to them. Okay, do this, do that, do this. But there are certain women who just say, okay, go and take this social medication. And when they take it, we just find out they just get their solution from there. Because what they just need is, okay, I'm trying as much as possible not to mention the medication so people don't self-medicate. Yeah. So there are certain medication we give to them.
Later, yeah.
There are certain medication we give to them to induce and to induce in ovulation, and also advise them on what to do. Okay, after you've taken this social medication, this is how you do, you and your husband, and so as to help. So, but then when all those ones don't work, which a lot of percentage of women, it helps. And there are certain clinic where people put money to say, if it's just the medication, this infertility clinic I've worked, they can even give women this medication at a very subsidized amount. Yeah. So
you mean hospital sells medicine for cheap price? Because I know that if you want to get
I work in a federal hospital, so it's right there.
All right. Okay. Are there any advancement in reproductive technology that have significant difference in infertility treatment?
Oh, yes. Like even the in vitro fertilization, or there's even the one where we can kind of like harvest the woman's egg. We harvest the woman's egg and then take the man's semen, and then we do it outside, like in the lab, in a petri dish. You do it there, and then when it has fertilized, then you introduce it back to the woman's but to the woman's womb, and use the word. So also that also creates a higher chance. There are even certain women that we give medication, a particular medication to. Once they've taken it, instead of us to advise them, okay, meet with your husband from now, the chances of that, of the, what is the word, a positive outcome is kind of low. So we do the artificial, we take the semen and we introduce it artificially into the woman. So it also increases the chance of them getting pregnant.
Okay. I also want to ask, I want you to touch on fibroid, because I know fibroid is set as one of the issues where women tend to like not conceive often as they would. So would you want to touch on fibroid a bit?
Oh, sure. When it comes to fibroid, I would say it's the location of the fibroid. There are several locations in, will I use the word, a human womb or ovary. If I show in my head, I'm already drawing the whole diagram of how it should be. Yeah, so there are certain locations of fibroid, but there are two locations that kind of like affect fertility. When a woman have fibroid in those, fibroid is like a benign tumor. They can't really say, oh, this is what is causing it. Just like, oh, we don't know what causes this cancer also. But it's not malignant. It's something you can treat and it's okay. So there are two locations of fibroid a woman can have, which is either called submucosa or intercavitary. So when the fibroid is located in these two places, it's hard for a woman to conceive.
The submucosa, where is it at? And the other one you spoke about,
intercavitary.
Yeah,
so it's just I don't know how to explain it without a board. Yes, without a board, there's no way I can just explain it. But those two locations, according to research, those are the main ones that causes it. Women that has those locations, fibroid in those locations, it's very hard for them to conceive. But then it's easily treatable. Once surgery and you remove it, they are fine. They conceive naturally.
There are some situations whereby you remove it and it will grow again. And there are also a situation, I can remember one of our guests said you can take in while having fibroid and you remove everything together. I don't know how.
Yeah, it's possible. That's why I'm saying location. So location affects some women. Some women, even with fibroid, they get pregnant. So they are pregnant while still having fibroid. You see some of them in a large abdomen, like, oh, you are 5 months, but it's looking like 8 months because they're carrying their baby alongside the fibroid. Those kind of pregnancies are termed high weeks pregnancy because the food, or will I say the nutrients your baby should be receiving, or that fibroid, because it's a tumor, he's trying to take every nutrient, every blood, he's trying to have it to himself. So those pregnancies are termed high weeks, but it doesn't stop the woman from carrying her child. So in those women, we used to advise them, you're going to give birth through cesarean section. So once we deliver your baby, we just remove it. Or some we advise them, don't worry, once we deliver the baby and you heal a bit, you come back and remove the fibroid.
Okay, are there symptoms of fibroid, like before, something you look out for to ascertain whether you have fibroid or not?
The woman can experience heavy menstruation. They will tell you that before they can use just 2 pads in a day, but now they are using like 5 pads in a day. There's heavy menstruation. They can have cramps as well. Same symptom of endometriosis. They can have severe cramp. They can even experience pain during sexual intercourse as well. Yeah, so those are the kind of signs a woman with fibroid can be having. And then this abdominal distension, just my tummy used to be very flat, but I noticed like even if I ignore it, it's still
Take my stomach. Because my stomach is very, very flat, but all of a sudden I'm noticing it is good. Please, I have to talk after this program. I don't understand why Victoria was started laughing. What? Okay, sorry, you said it already. So you were talking about abdominal.
Yes, abdominal distension. Like, the woman is experiencing, like, my tummy is just so big, and some women have it naturally, just fat or something like that.
You're feeling guilty.
Yeah, it can even be just bloating. Yeah. But this one is something that is consistent. It's there. You're having the symptoms as well: the pain, the heavy menstruation, the pain during sexual intercourse, and all that.
Okay, earlier you spoke about irregular ovulation. Are there causes of that? What causes it? Because there's one time, myself, I've shared the story. My friend, like the story Victoria shared earlier, that the person does not see menses, like it's irregular, so it comes and goes. And she was pregnant for like 4 months. And normally she does not see her menses, there's no ovulation, nothing. So she'd never know that she was pregnant for 4 good months. What exactly is the causes of this irregular ovulation?
Okay, polycystic ovarian syndrome can be a cause of irregular menstruation.
Okay.
Yeah, so that's one major cause of irregular menstruation. There can also be some uterine abnormalities that will cause irregular menstruations. So that's the main 2 ones I can really
can
explain.
it be corrected?
You say?
Can it be corrected?
Oh, of course. Even like I said, because the oligo-ovulation, which is the irregular menstruation or irregular ovulation, there are certain medical pills we give to patients and get corrected.
Okay, for those young ones that are really watching us at this hour, I want to take us through how you can calculate your ovulation, the processes and whatnot.
Okay, your cycle starts from your day 1 of menstruation.
Okay.
So you start counting. Once you are seeing your menses now, that's day 1, day 2, you start counting. Mostly your ovulation is on the day 14 of your cycle. So okay, if you're at 28th day, if your cycle is 28th day, it's 14. Some women, I told you, some is 21, some is 35, so depending. So some people can't even calculate it. So we usually advise just download these current apps. It helps you.
But they are not usually somehow adequate enough. Sometimes you might, it will say, okay, for instance, they'll ask you to impute your days of cycle, and not everybody know what days, how many days they have to calculate. And
I have a very nice app then. I have a very nice app. I don't know what it's called, but I have it on.
You wouldn't even say it on the show.
Okay, there's one I'm actually using. I imputed my details and the rest, but every month it keeps changing.
Yeah,
I have to put a new date. It keeps changing. It's only maybe once, like from this month to next month, it can just tally. But for subsequent months, they'll ask me, you've not seen, maybe it's my delay for a day. It helps though, but the fact that it's not accurate.
Yeah, if you notice, if you're using your app, which is mostly it helps these days, like you see there's an average They gives you an average. That average tells you your number of cycles that you experience. Some you see 25, you see 26. They've calculated, because sometimes it means you're not seeing your menstruation at exactly 28 days or 27 days. Maybe it's between 27, 29. So they calculate the average and tell you, oh, you're a 28-day cycle. So if you don't notice the app at the bottom of it, you just keep seeing the number of days.
Okay, I've also heard that those who see their cycle in 35 days, it's actually something that is rare. Is it true?
Yeah, it's quite rare. And it's something that once you start having 35 or more, you should already start getting worried.
Okay, we are trying to round up. Can you just give advice to women who are having infertility issues, that are concerned about giving birth?
Okay.
And how they can navigate this infertility journey.
Okay. So we already understand what infertility is. That it has to do with when a woman is trying to conceive and unable to get pregnant, 12 months of regular unprotected sexual intercourse in a woman less than 35 years, and 6 months in a woman more than 35 years. So when you're within that range, there's nothing to be afraid of. You've heard us say the causes, and so if you just find yourself in that category, see a doctor.
See a doctor, very important and valid point to leave you with. See a doctor. Like she said, she doesn't advocate for traditional means and the rest, but I know some of you still believe in it. However, and one thing she said also, despite the fact that we kind of streamline it to female gender, it is a collective thing. It is a collective issue, and everybody should be involved in it, both the family, the friends, the husband, the relations. Do not just leave it for the woman alone, because it can impact on her stress, her mental health, and even her emotions and the like. So to have your partner succeed in terms of fertility, be by her side and support her. As usual, I am Victoria Agbi.
I am Pamela Ajaero. Everyone has a role to play in this infertility issue, so I urge us to do our best and support every woman out there who is going through this crisis. Bye for now.
Bye.